Good afternoon, everyone, and welcome to IPC Journal Club today. Phil and I are delighted to be joined by Kerry Holden, who's going to speak to us later about addressing health inequalities using IPC. I'm really excited to see what Kerry has to say to us later, and I hope that we'll get lots of questions in the Q&A box as we're going through. So just a little bit of background about IPC Journal Club, what it is and what we're trying to achieve. So we're trying to aim to provide some insight into a topical paper, to generate some discussion, and actually for Phil and I and Kerry, the discussion is always the best bit, to provide opportunities for you for CPD, to exercise your critical thinking skills. We're keen to build confidence in the network for independent research and study, to foster a network of enthusiasts and, in an ideal world, have a bit of fun. Just to let you know, all of the events are recorded and available online after the event. So, without further ado, I'm delighted that Kerry has joined us today. So Kerry is the IPS Vice President alongside her NHS day job. So Kerry, over to you.
Thanks, John. Yes, I'm in uniform because I am at that day job, absolutely. So I've locked the door so we don't have the interactions that we normally often get in IPC, which is crazy busyness, isn't it? So I'm hoping I'm to start sharing my slides. There we go. Is that showing? That's always a
Good to
good
see
start.
them.
Brilliant,
Yeah,
fantastic.
thanks, Kerry.
Fantastic. Thanks, Phil. So huge thank you for inviting me along today to come and talk about health inequalities, and particularly in infectious diseases. And if anyone has, hopefully people have had the chance and the opportunity to have a look at the paper, because it's certainly been something that I've found fascinating and have put very clearly a bit of a disclaimer, and I pinching a little bit of Martin Keenan's bit from when he did his journal club. I am a passionate amateur and have learned a lot in the last few weeks and months really related to health inequalities. And I am no expert, but certainly, hopefully, if I can encourage people to be equally passionate amateurs down the line, I would encourage that. Certainly, if my challenge to you by the end of this session is to hopefully think a little bit differently, maybe, but also to hopefully go out and find those people that might be those specialists in health inequalities, because they certainly are out there, particularly as the sort of national changes have happened. But I'm very aware we may have an international sort of audience today, so I will try and reflect some of those things as well. So when I was creating the slides, actually, and I will kind of go a little through about health inequalities, just a little bit of context before we go and talk about the actual article, because I think for many of us, it feels fairly new. It's a little bit kind of a little bit novel for us, and I'm hoping that will change, because we need to move away from health inequalities being a bit of a novel add-on to what we do in our work. We need to make it as business as usual. But I was trying to look back about when has this ever been, how long have we been thinking about health inequalities? And as I say, it was when I was doing these slides in January, it happens to be Martin Luther King Jr. Day in America, and this kind of really start for me really in 1966. He quoted this at a kind of a medical conference, basically saying that of all the forms of inequality, injustice in health is the most shocking and the most inhuman, because it often results in physical death. So I think if that's a reason to want to be a part of this is what we're here for. That's what I do. My job as a preventionist is to prevent harm and prevent death. So hopefully come along with the ride for me, and hopefully you'll feel equally as inspired to do something different. So what are health inequalities? And you'll see throughout my slides, I've put a little QR code that might be something that might be useful for additional information. The King's Fund is fantastic. If you haven't had a look about health inequalities, there's absolutely massive amounts of information about where we've been and where we need to go to from a health inequalities point of view. But essentially, what is really important is these are avoidable. These are preventable. Unfortunately, for a lot of people, they're quite deep rooted, and they're generally unfair, unjust, and they may make a difference to people's health between different groups. And some of the four categories of main groups that you'll talk about when you see the language around health inequalities are related often to socioeconomic factors, so income and employment, geography in terms of the region. Is it urban? Is it rural? Is it location based on where you live? Specific characteristics or protected characteristics that are probably more familiar with, so ethnicity and sexuality, and social exclusion groups, or sometimes they're called inclusion health groups, and these are generally our sort of people in society that are generally more vulnerable from a asylum seeking point of view, experiencing homelessness. And sadly, that those tends to be people that generally will face a multiple kind of levels of inequalities, and unfortunately they can perpetuate one another. So, you know, the effects of inequalities are multiplied for those that have more than one disadvantage. So this is the paper that I've hoped to choose today to have a look for you to have. Hopefully you've managed to have a look at it beforehand, that we're going to go through today at the Journal Club. So why did I choose this article? So if we go back to the sort of 6 domains of healthcare quality, and I always like to look at the Institute of Medicine, it's pretty the kind of renowned definition that we look at regards to quality in healthcare, and you'll see in that there's equitable. And this is about making sure we give access and fair provision of healthcare to the people that we serve in the communities from a healthcare perspective. So it's not about doing things equally, it's about how we might do things differently to make sure there's fairness in that. So in order to have good quality healthcare, it has to be equitable. So that's a really good place to start. And then we look back about where we've started in terms of where this initially originated. And sadly, I always listen to a report from Martin Keenan when he talked about the things that we've done in the point prevalence surveys with years and years where we talk about all these reports, but what have we done about it? And sadly, health inequalities is in a very similar position where we've had reports in 1980, reports in 1988, and the Marmot reviews that people will be familiar with. He's a sort of seminal person in health inequalities work that identifies that there's health inequalities, the need to tackle them, and actually what can be done to address those. Yeah, I don't think really we've made a really substantial impact in addressing these health inequalities, particularly I think from my perspective in infectious diseases and infection prevention and control and management. So I thought this was a fascinating piece when I was looking again, sort of saying, why should I be focusing on this type of paper? Why should it affect my practice? And I saw this Public Health England article from 2019 that said the things that we have potential threats to public health in England. And ironically, before the pandemic, it talked about antibiotic resistance. And I think most of us would probably be saying we've got that on our agenda. And there was issues with declining vaccination rates. And I think certainly the pandemic has really put a highlight on the importance of how we engage our vaccination programs with the communities that we look after, and highlighted some of the concerns that we had that we didn't quite get that right. Pandemic flu, and we say we're always seeing that just come out of a really bad flu season, emerging diseases, and we certainly see things like Candidaurus, things that are concerning to us. And at the bottom of that is health inequalities. And again, I don't quite think we've managed to really sort of nail that to say that's something we're actually working on or actively participating in. So yeah, I thought I'd add the fact that it said in here in the same document that there's an increased chance that we'll witness a global pandemic in the coming years, including the pandemic influenza or novel virus, it's just so-called disease X, and this was directly before the COVID pandemic. So what could we face with health inequalities if we don't start thinking about it now, so we're not caught short like we did unfortunately with the pandemic? And also just wanted, I'm sure probably people have seen this infographic quite a while. I think most people have seen it related to healthy access to service or access to services and things, and how we often think about equal being what we strive to do, but actually equal assumes that everyone benefits from the same support, and we know that isn't truth. And this is a very clear image of that, where the person who's got exactly the same is still not able to have access to seeing the football, the baseball game. But what we do need is equity, so everyone gets the support they need. But in reality, what we have is some people get more than what's needed and some people get significantly less. And that huge disparity means that people, particularly in infectious diseases, are higher risk of the kind of poor consequences and outcomes that you get as a result of not getting the same access to healthcare. And then we have the bigger picture of justice, where we know that we need to engage with our government and politics to make sure that the causes that actually cause that inequity in the first place are addressed, and we can remove some of those systemic barriers so that everyone actually has, you don't need to do anything separate or different because everyone has fair access from the start. But what's nice to see is that we are starting to see an impact now, I think, from seeing that we need to address health inequalities, and the National Action Plan, so the UK 5-year Action Plan for Antimicrobial Resistance 24-29 in the UK has said we're going to focus on health inequalities, and I say the QR code will show you the link to that. And what was interesting in that report, it really reinforces that good health is not spread equally in society. And the SBAR report from 22-23 showed this quite in a really visual way, where the AMR burden in the most deprived was higher. So the IMD, which is the Indices of Multiple Deprivation, that had so those are patients, people that live in communities that have sort of higher reduced socioeconomic sort of issue problems, so they generally have less financial money and gains and things like that. They experienced higher burdens of bloodstream infections. So we're already seeing this in some of the patients that we are seeing, and are we doing something about it specifically? And those that had the least deprived had the lower rates. And also in this same report, which I thought was interesting, it said that research demonstrated that 10% of antibiotics in general practice are prescribed to only 0.5% of the registered patients, with some patients exposed to more than 10 courses of antibiotics. So that made me question, who are these patients? Are these patients experience health inequalities? And actually, could we do something specific with that group of patients to reduce their unnecessary need and appropriate use of antibiotics, and therefore hopefully prevent some of the concerns that we see with obviously inappropriate antibiotic use and the resistance that subsequently happens. And then I also came across this paper, and I thought it's really important that we have learned the lessons from COVID and the pandemic, and it really showed and spotlight for many of us, about the kind of the impacts of health inequalities. And this one really flagged that up. And I only pull this up because, interestingly, the paper that we're about to have a look at didn't look at COVID, because there was so much going on already about COVID, and the paper was commissioned by Public Health England as it was then. So just to reiterate that, COVID infections and flu do disproportionately affect people that might have face some of these health inequalities. So flu admission rates being higher in the most deprived areas, so much higher than those that are in the least deprived areas. COVID admissions in a similar fashion. And then when we look at ethnicity risk in terms of flu, we see persistent differences between for ethnic groups, and then this data demonstrated that there was higher admission rates, particularly in the Pakistani ethnic group cohort of patients, and then similarly with Black African Caribbean or Black British ethnic groups had higher rates of admission rates for influenza as well. So, as I say, the pandemic definitely demonstrated that morbidity and mortality was significantly higher in those most deprived areas, and this graph demonstrates that. What I really wanted to highlight from this was that resulting priorities came out from this work, and really, for me, it said accelerating the preventative programs which proactively engage those at risk of poor health outcomes. That certainly rings true for me. I think I really take the prevention role in my role very seriously, and I think that's where we can make a significant difference as a community of practitioners. And as a result of the sort of the work from the pandemics, you'll probably be familiar, and just to kind of give you some background to this, is the Core 20+5 work that's come through, which is developed by the National Healthcare Inequalities Improvement Programme to support the reduction of healthcare inequalities, and focused specifically on this core 20, where it's basically where the most deprived 20% of the national population are living in. And that approach also defines some of the population groups that may face those disadvantages. So that's the plus aspect. These are the inclusion groups and communities, ethnic minority communities, that may be affected by the deprivation, for example, like homelessness, some of asylum seekers, and those in contact potentially with the criminal justice system, like prisons and things. So they have focused that they need some targeted interactions and interventions to tackle clinical areas of health inequality, and those are those sort of 5 things at the bottom: so maternity, severe illness, chronic respiratory disease. And that kind of flagged up to me a little bit about what we could be doing in terms of pneumonia and the works with that, early cancer diagnosis, and hypertension case finding. And obviously between that thread of that is smoking cessation. And then there's also one for children as well, and similar things. So looking at asthma. And what interestingly on here was oral health. So just briefly, just what those inclusion health groups are. So those, as we mentioned before, those plus population groups on that core 20 plus, that are the ethnic minorities, the inclusion health groups, people with learning disabilities and autistic people, coastal communities, so pockets of deprivation hidden amongst relative affluence, and we see that particularly in the southwest where I work, people with multiple morbidities and protected characteristics. So just to sort of understand the language, it's important when you're delivering someone working with some of these people that you understand what we're talking about when they're referencing this. And just why it's so important that we look at inclusion health groups, particularly because they consistently have faced a higher rate of infection compared to the general population. And this article from in the Lancet in even 2017 demonstrated that they were 11 times more likely to die of infection in these higher risk groups than the things that we generally face every day. So particularly things like Group A strep and MRSA that tend to be a bit of our bread and butter of works of infection prevention. And I'm sure I probably don't need to say this, but why does this matter? And I think some of the statistics are incredibly scary, and these are just some of them. But the fact that the life expectancy of somebody who's got a learning disability and if their ethnicity is black, then your life expectancy is 34 years old. That's kind of the huge disparity and the change when you're thinking about what most people's life expectancy that doesn't meet some of these these backgrounds is shocking. So we need to be looking to understand it. Things like if you're a black woman, you're 4 times more likely to die in childbirth or in the year following. Is there something that we could be doing with that? So yeah, definitely food for thought. And I think the particularly related to some of the healthcare contact stuff at the bottom, 1 in 8 emergency hospital admissions in the winter are because of worsening chronic obstructive pulmonary disease, and they're mostly within the core 20+ communities. Is there something there? Is the presentation infection effective exacerbation? Is there something that we could be doing within that? We need to explore it. So let's get on to the article. So as I say, hopefully you've managed to have a look at it. It was commissioned by Public Health England, and as a result, it reflects very much UK population. So apologies to those that are joining internationally. Hopefully some of the things I've discussed earlier might still be useful. So it was a systematic overview of reviews. It looks specifically at some of those groups that we've just reflected in, and particularly the evidence around the inclusion health groups, the protected characteristics, and socioeconomic inequalities. So again, looking at social class, occupation, deprivation measures were measured as individual or aggregated level, and look specifically at focused infectious diseases like TB, HIV, sexually transmitted infections, hepatitis C, and then looked at vaccination, antimicrobial resistance. However, it did include eligible reviews from other infectious diseases. I will say that it didn't, as I say, explicitly excluded stuff on COVID because there was other data sets going on at the same time. So it had very specific inclusion and exclusion criteria. So it was really helpful to them to be able to see what papers and what insights you can potentially essentially apply to your own environments and your own settings. So from UK populations or other high income countries, so therefore excluded anything that was sort of outside of the UK populations or papers that were results from low income countries. It looked at those exposure groups I've just referred to, and the outcomes were looking at inequalities relating to incidence, prevalence and consequences of infectious diseases. It had, as I say, it included quite a lot of reviews, but had to have some specifics about the literature reviews that the reports followed. So it had to have explicit objectives, clear search strategies and eligibility criteria based on the exposure and the outcome sets. There was no language restrictions, and it was published. Everything was that was included in the reviews were published from 2000 onwards. And you'll see from the actual the article, it said that 95% of the data was published after 2010. So again, sort of demonstrates this is still fairly new in terms of how our evidence base is being contributed to it. And at 58 or so, 54% included meta-analysis, whilst the remaining studies sort of use a narrative descriptive synthesis approach. It excluded qualitative studies, which I thought might be a shame, but I recognise why they're doing it. But maybe that's something that would be a bit of a gap, and maybe something to look forward, because I do always appreciate that kind of qualitative approach to sort of these things, and how the experiences of people that are actually living with health inequalities would be useful to see those impacts directly through their words and through potentially the staff that look after them. It excluded review protocols, but they did look at the titles to check to see if there was any findings that had been published as a result of the implementation of that. So those were included. It excluded reviews on COVID, and excluded reviews on focus on travel-related infections. So in terms of how that article, how the authors did that sort of review to understand what articles to include, they did a review of 4 databases. They did a search strategy using synonyms and medical subject headings, terms for inequalities and for inclusion health groups, protected characteristics and socioeconomic factors, which they combine those. They then got all of the titles from all of those articles, and then pulled all of the abstracts as a result of that. They then by a single reviewer looked at all of those titles and abstracts to see if any of them met the kind of the criteria in the inclusion criteria, which I thought was interesting. They did have 10% of those second checked, but I would probably, I'm recognizing one of the limitations of one of the next slides is they probably did miss out some of the kind of articles that they could have included because they were doing that high level screening of just titles and abstracts to see if it met it. And then from that, they requested the full articles, and then 2 reviewers independently assessed the review quality using the assessment of multiple systematic reviews, or the AmStar 2 checklist. And then they sort of had any disagreements with themselves discussed between the 2 reviewers. So out of all of that, they then managed to get sort of 70, I think it was, I'm trying to remember how many it was now, it was 108, sorry, articles that they managed to get, and was able to kind of produce the outputs of in the discussion. They didn't, I will say, perform any overall rating of confidence for each review, but to provide a sense of overall quality of the evidence, they calculated the proportion of reviews which fulfilled each of the AmStar items. So they did sort of do assessment of the quality of the outputs of the reviews. I really like this image from it, so I thought it'd be useful because it's quite a nice visual aid just to demonstrate what is the actual reviews data, how many reviews are being done depending on the kind of some of the variables within each of those 3 study areas that we're looking at. So this matrix shows the number of reviews identified for each dimension of inequality and infectious disease topic and the colour ranges. So for anything in red indicates where no review and then was identified, up to green for a maximum of a number of reviews. So I think 19 was the highest when I had a look, for AMR, STIs, and sexually transmitted infections. So yeah, just some concerning stuff really, looking at facts. I thought was interesting that there was nothing that they picked up on, no reviews on vaccination in pregnancy and maternity, and the impacts of the health inequality of that, which I thought was fascinating given that we have quite an intense vaccination programme for that group, knowing that we hadn't really addressed anything specifically for that. So a lot of red. So hopefully that you'll be inspired to potentially try and do some reviews or some research of your own to try and contribute to the actual evidence base. I will note that they didn't, obviously, and I'll just pick this up in my limitations, they didn't include primary studies. So these were reviews of reviews. So it had to, we may have missed some particular insights or some evidence that might have helped to contribute to the evidence base if it was just a primary review or primary resource rather than a review. And again, this was their assessment of the quality of some of the reviews, and it just if you look into the red, that was where there was some of the assessment wasn't kind of able to be assessed effectively, and they weren't compliant with the assessment of multiple systematic reviews V2 score, and then some elements were no meta-analysis conducted at all. So you'll see that in the grey, that they weren't able to assess them. So what did we find? So looking at the evidence, the protected characteristics, there were 74 reviews of those, and there was, but they only found clear evidence for health inequalities by ethnicity and sexual orientation. They demonstrated the suggestion of higher rates of TB, HIV, STI, and under vaccination in people with in an ethnic minority, and kind of aligns to what we'd seen in sort of the COVID times in terms of that similar population group. They found 10 reviews mainly focused on men who have sex with men in terms of the protected characteristic of sexual orientation, where they saw higher rates of hepatitis B virus and C, rates higher than the general population, but no reviews looked at vaccination. And then they've had evidence for inequalities evidence for inequalities by age and sex was mixed, and actually protected characteristic evidence was a bit inconclusive based on that. Looking at the inclusion half group, so again, these are the groups that generally are sort of maybe asylum seekers or vulnerable migrants. There was 104 reviews within this area, and generally showed again that there were these groups were at higher risk of infectious disease, AMR, and under vaccination, and that those reviews mostly looked at migrant and vulnerable migrants. And I suspect there's probably, with some of the sort of changes more recently, with us a lot of having sort of immigrant sort of hotels and things, it'd be interesting to see how that will affect the evidence base over the last sort of couple of years. Certainly higher rates of most of the infectious diseases reviewed and deaths from TB, and I think they obviously saw higher increase of rates of multi-drug resistant TB in particular. Some of our travelling communities had higher rates of under vaccination and therefore high rates potentially of some of those other infections, particularly TB and HIV was also referenced. Homelessness had high rates of infectious diseases, and if I'm honest, probably most of our interactions from an IPC point of view has probably been this community, and generally see higher incidence of things like bloodstream infections and this sort of reference that, but there was not much on the vaccination. And then sex workers, again, had higher risks of our bloodborne viruses. Looking at the socioeconomic factor groups, there was 50 reviews in this area, and as probably alluded to in some of the other aspects that I've seen, where we said higher incidence of deprivation, we've seen higher incidences of infectious diseases, AMR, and under vaccination. So that was associated often with lower income, lower educational attainment, unemployment, higher deprivation areas, lower socioeconomic status, and poor living conditions. So yeah, generally seeing a higher issues with or most of those infectious diseases that they're reviewed as a result of some of those socioeconomic inequalities. What was also found fascinating that they said that childhood vaccination compliance was lower in the younger mothers and parents, and something probably not necessarily considered before. Based on the review, I would say that there was still some work to be done in some of the age and sex inequalities, and particularly in the protected characteristics within that. But they generally saw a higher incidence of risk. Certainly gaps in the research, so we still got some more work to do about religion, disability, transgenderism, and pregnancy, which I alluded to earlier with infectious diseases, and because a lot of the evidence that was there wasn't quite enough there really, and it was a little bit inconsistent. Certainly reinforces, and hopefully this will be the message certainly coming from this session, is that we do need to target interventions for high risk groups. And I think rather than focus on individual infections, could we contribute significantly to reducing all infectious disease burden, because we're targeting the health group, the group that's experiencing inequality rather than particular infectious diseases. Already referenced a little bit about the limitations of the study. So some of the relevant reviews may have been missed in the study due to the selection process because of that highlighted, looking at just the abstracts and the titles. Some of the underserved populations, such as people who inject drugs and prisoners, weren't covered, which was a shame, but it wasn't within the scope of the work to happen. So it would be expected to do that. So it'd be interesting if they widen their inclusion criteria, whether we'd have got a bit more information, but certainly would be useful to see that, particularly as we generally tend to see higher increases of bloodstream infections, particularly in our inject drug communities, and particularly from a prisoner point of view, we often see things like outbreaks in those sorts of environments because of sort of close living quarters. The quality of the included reviews did vary, and that obviously some of them weren't systematic reviews utilising sort of meta-analysis designs. So the AMSTAR was useful to be able to assess the quality, and whether they included it in some of the summaries, but it wasn't consistently applied, and we didn't have good quality everything for everything. Some of the study was an overview of the reviews. It didn't include evidence from primary studies, which I'd already referenced earlier, and there were quite a variance in some of the in the study designs and the populations, which does make it quite difficult, I imagine, as authors, though, when they were trying to look at all of the findings and trying to make consistent findings with everything, because they're so different in the reviews. It was quite difficult to kind of pull to say everything could be consistently applied. So they do err on the side of caution about some of the outputs of it, but generally they tend to see fairly similar themes and trends. So what does this mean for us in IPC? So hopefully, as I say, it certainly puts it at the forefront of our minds that we know that patients and our communities that we look after will face health inequalities, and that will mean that they'll have higher risk of acquiring and transmitting and being more susceptible to infectious diseases, and we need to play a part in how we tailor our interventions, particularly with infection prevention and management, so they aren't sort of broad stroked and everyone fits all, that we need to be considering the populations and the people that we're looking after, so that we can make sure that we are doing the best we can that's going to be the best for them, rather than sort of which will have a whole impact on how we look after all people and improving their health and well-being of the whole population by doing some targeted interventions for specific groups. So if I had to sort of summarize it really in terms of what I would like to do in tackling a health inequality approach, I think we definitely need to have a more coordinated approach across various sectors and community groups. Within IPC, I feel sometimes we're quite siloed, and when I look up and I look at the amount of particular fantastic volunteer groups that are in our communities that are absolutely desperate for some direction about how they can support the people that they look after, and maybe we could help them within that. Focus on prevention, of course. We we always say prevention is better than cure, but I really do mean it in that. And actually, if we can help upskill the people that we work with or the people that we look after to be able to prevent infections better, we can hopefully prevent the unnecessary admission to hospital, the kind of contacts of healthcare that they need to have. I challenge us to maybe collect our data better. I know only the other day I was speaking to my team, and we were saying about how are we including patient ethnicity and postcodes. So can we correlate any of our postcodes with any of those core 20 plus spaces that we can say, actually, this might be something we need to target in terms of our intervention, particularly if we see higher incidences of infection in those areas. So yeah, how are we making sure we're able to target our high incidence risk groups if we don't know who they are? Consider how we deliver health education, and this is a really important bit. With the average reading age in the UK 7 years old, are we our education, our promotion, potentially our prevention messages, are they hitting that they're going to be able to be understood and then utilised? We do need to address racism and discrimination. We need to make sure that people feel safe in the environments that we work in, and we all have a part to play with that. How we involve local communities and patients in decision making. We need to be co-designing our interventions with the people that are going to then receive some of that care and that intervention and support. So how are we doing that? Are we holding ourselves to account to make sure we're not just thinking that this should fit, this should work, and then putting that into place? Building trust with some of those marginalised communities is really important. People aren't going to take any messages from us or any prevention strategies or interventions if they don't trust us, and we need to be making sure we're developing that rapport with those people. Educate the workforce on health inequalities. As I say, a lot of people don't know how can they make a difference, how they can impact, and it's really interesting in the evidence and the guidance that's out there. It's still seen as quite a novel thing to do, and actually we need to educate our workforce and the people that we look after on this, so that we can make it business as usual. That it isn't an added on after effect. It's something that we do consistently through all of our improvement works and the interventions that we do, and we really need to share best practice and learn from each other. I was listening to some fantastic talks, and I listened to a fantastic speaker the other day that was talking about some of the work that she's doing in a community around homelessness, and she's doing skin health prevention, has seen reductions in wound infections and resulting admissions as a result of bacteremias, just because she goes into once a week, she goes into a setting where she does dressings and skin health care for people that are homeless. It's a fantastic piece of work, massively inspiring, but I was like, you need to get this all out there because we aren't very good at sharing it. And just finally, just a little bit about kind of Gloucestershire, and just kind of give you a bit of insight about, actually, does this affect us? And this is some data that we pulled out last year in preparation for our strategy. And I say this because we've made health inequalities a core golden thread of our infection prevention management strategy within Gloucestershire. And this is some of the data that we utilise to demonstrate why we needed to do that, and particularly some of the interventions that subsequently come through as a result of it. But we saw that, in patients that are admitted in our trust with a primary diagnosis of bacterial pneumonia, UTI and sepsis, so kind of some of the big top healthcare associated infections and some of the infections we like to prevent in hospital were coming significantly from the most deprived parts of the county. And we have quite an interesting sort of diversity across Gloucestershire, because we have Cheltenham, and I'm sure people will be familiar with the kind of very kind of high levels of there's no levels of deprivation in those areas compared to some of the areas that we might see in Gloucester. So certainly seeing an impact of that. So yeah, look at your data, you'll probably see that this is affecting your communities and your populations. And then finally, just a little bit about particularly about learning disabilities, and just demonstrating one small group of people that we might have to look at in terms of how we might be able to impact from an IPC point of view, where we see significant life expectancy differences between people with learning disabilities and autism in our population. I mean, that gap is 19 years in Gloucestershire. I'd really encourage you to have a look at your leader reports, because they're helpful. They look at patients that have learning disabilities, or people in the communities that have learning disabilities, and sort of contributing causes to their death. And what we saw was that at an average of 2 deaths per month occurring in this group, and the leading cause was pneumonia, with a specific increase in COVID times. And so therefore, so what does that mean for us? Well, actually, we could be looking at as a community of practitioners in infection prevention and management, looking at our vaccination programs, mouth care and hydration is something that probably most of us are probably doing something within our acute settings. Are we widening this out? Are we looking at how we can support a whole system approach to that? And then certainly looking about how we then recognise and respond to deteriorating patients and particularly about sepsis management and infection prevention to hopefully prevent that sepsis from happening in the first place. If you're interested and want to have a look at other case studies, I'd encourage you to go, again, the QR code. The NHS England website has some fantastic case studies about certain things that they've done to address health inequalities and some of the interventions they've done. Sometimes it's helpful just to see what people have, how they've done it and who they've spoken to and how they've managed to do it. I have to say the one that I was talking about earlier about the kind of the person that's done some work about tissue viability for homeless in communities identified that that just by going into an area and they'd lost one of their services and they just filled it with this. So it was just purely incidental. So sometimes you can fall upon these things, but sometimes we need just a bit of a steer. So I'd please encourage people, if you've got something that you've done in your environment, to do share that with NHS England, because this is a platform that people can utilise to kind of echo and share and hopefully replicate. So I'm going to be quiet in a moment, but what I would say is my focus to you and my message to you is really clear, that to reduce the burden of infectious diseases, we need to recognise health inequalities and we need to tackle those through doing that together. We need to be informed, so we need to have a workforce that knows how to do it, and it's going to take continuous efforts. This isn't a one-stop win. We have to continually work at it, and once we unfortunately probably replace and then improve some of the health inequalities with one, we end up replacing it with another. So this is something that I think we need to continually make a part of our agendas, our strategies and our programs of work. And it's nice to see that nationally that's been recognised, but often these things rely upon the people on the ground who deliver the care directly to influence the change. So be part of that change. So thanks for listening. I'll stop sharing my screen.
Thanks so much, Kerry.
There we go.
There's a lot to do, isn't there?
There is a bit, yeah. When I was writing it, I was thinking, how do I make this shorter? But I thought, no, I kind of, there's so much to do. I need to tell everyone a little bit about everything.
Yeah, well, the passion really comes over in the way that you present it. So thanks very much.
Thanks.
Yeah, so people can use the Q&A if they'd like to ask Kerry questions. I know I've got tons personally, so I'll start. I think just my personal reflection on health inequalities in AMR, looking at that Lancet study, and they were talking about the number of deaths and how it was differing in different parts of the world. So I know you talked about the UK perspective, but it was talking about, you know, the amount of deaths from AMR in sub-Saharan Africa and how health inequalities there play a big role in that. So, you know, it definitely expands outside of the UK and the international picture, doesn't it?
Doesn't it just? And that's what's, I think that's the only thing you can universally apply. Unfortunately, the nuances will be different, but you can certainly say that actually this is not unique to any area. And if anything, some of those health inequalities are even more, disparity against them is even bigger in certain areas, I suspect.
Yeah. So, you know, the paper was a really good one because I thought it brought together lots of different themes and, you know, talked about what kind of data is there. And I think there was things that we associate with IPC and infectious disease a lot of the time that we see and how that impacts certain groups. I guess my question is that where do you think that we can make the most impact? And I appreciate that's a really broad question.
Yes.
But, you know, where do you think, is it targeting a particular infectious disease? Is it targeting a particular group within that health inequality? What do you think?
Oh, it's a really good question, actually. And when I always think about generally how we approach IPC, I think sometimes we're a bit organism specific in our ways of it. And I think, unfortunately, the way in the UK, we are very good at sort of, the C. diff rates and the MRS rates. And then we forget to lift our head up about the wider picture of all the healthcare associated infections that our populations can have an impact for. So I think we need to be a bit smarter. I think we have a lot of data in IPC, and I don't think we quite pull out where the actual issues are sometimes, and actually who are the people behind these numbers. And I do think we could probably be better at saying, actually, if we collected some of our data in terms of like the ethnicity and the populations, that I think would inevitably enable us to see where some of those issues are, rather than trying to say, well, we'll focus on flu today and see what happens. I think let's actually look at the community of people that attend probably for any infectious disease, and then see if there's anything that's that's coming out of that particularly, but also using the data that we currently have to then see, is there any particular pockets of groups or any takeaways that could be something specifically that we need to target. Classic thing I think we've said in our strategy is so that every person that's doing any part of the work stream has to collect that ethnicity and postcode data as a minimum data set now, so that at least when we're doing this work, even if we incidentally find something, that will help us, give us a steer, rather than trying to say, oh, we're going to focus on, I mean, we'll have our own priorities, won't we? I'm sure most of us have got C. difficile programs to try and reduce and stuff, but there might be something in that, you know. Incidentally, we haven't found anything directly in a group that we're seeing higher incidences of relapse and recurrence, but geographically some people might do, particularly if they have, I mean, that's why really interesting to understand where that population or group that are consistently getting antibiotics from. I'd be interested to see that, because is there something in that? Is it a particular group that aren't getting access or having lots of access to antibiotics? It might be that, you know, they are of that group might not be able to have sick leave because of their work, or they won't be able to afford to live if they don't go to work, so they have to have antibiotics, whereas most people would generally just be okay. So it'd be interesting to see that. I mean, there's lots of questions. As you said, there's lots of work to do, and there's lots of unanswered questions, but we need to start asking them. And at the moment, I don't think we do ask those questions to get the right information.
Yeah, I mean, that stat that you presented around the antibiotics in that really small group of the population, you know, 10 antibiotic, you know, I definitely think there might be something there with C. diff, but it also, I guess, goes the other way, doesn't it, about the people who really need the antibiotics and who aren't getting them.
Yeah, absolutely.
And it's that contrast. Thanks, Kerry. I'm gonna pass to John.
Yeah, no worries.
Yeah, thanks, Kerry. I really enjoyed that. Really, really fascinating and quite confronting, actually, some of the information you went through. I was confronted particularly by some of the stats that if you're Black and if you have a learning disability, your average age is 34 years, was it? Or 36?
34. Yeah, 34.
And if you're a Black woman, you're 4 times more likely to die during childbirth rather. And if you come from a deprived area, you're 2.5 times more likely to be admitted to hospital with the flu. So thinking about one of the things we can do to help practically with our IPC hat on, and one of those areas I think is advocacy, both locally and regionally and as a profession. How do you think we can put these shocking stats almost to work for us in making the case that we need to change the way we configure our systems to address healthcare inequalities?
Yeah, it's a really good question, actually. And I think we do have those. I mean, in my system already, we have people sort of saying, look, this is an issue. We need to do something about it. And they are saying, look, this is really stark. I think if you can localize those stats to your own environments, then even more powerful, because those are the people that use your services. Those are your brothers, your sisters, your parents. Those are the people that are in your community that actually, interestingly, we use a lot of patient stories, don't we, and a lot of things to have that power and design. So I think we should be absolutely doing this to say, look, let's get in front of our commissioners who are in our integrated care board. So kind of in terms of the people that are decision makers, to tell them that this is actually the impact, you know, and actually what we see is then, you know, they have all those admissions. If we can prevent some of those admissions, let's put some investment in that, because then it puts some of the reduced stress on our acute services in particular. I do think we need to train our workforce to ask that as well. I don't know how many people have ever had training about this. I don't think we are very good at telling people about health inequalities and how to recognize them, and how we, you know, in our organization, we're very much empowered to try and make a difference when you can, you know, what do they say, seek forgiveness, ask permission later, in some of our interventions. But how do you know who to go and tackle and who to look after, you know, what things you should be doing if you just sort of broad stroking everything? And we're really good at that. I think we generally try and get the best bang for our buck, but actually is it doing that? I don't know if we do. So yeah, I'd be interested. What do you think, John? I'm pushing it back on you. What do you think?
So I think what you said about trying to find something that is meaningful locally is incredibly important. So something that actually you can say about your community and that you serve. I think that's probably the best way to do it, because it means most to people when it's personal.
Yeah, absolutely. I mean, what's been fascinating is we've done a big work in Gloucestershire about our C-section SSIs and surgical site infection rates, and it sort of a year and a bit in, we thought, oh my gosh, we haven't looked at any health inequality data, and it's only now we're starting to pull some of that data sets in and recognizing, because we do bundles, don't we? We do bundles of care. We're very good in IPC of everyone gets this, so then everyone should be okay. But actually, who's slipping through the net despite that? And actually, is some of our, we're at 8% of our SSI rates, and we want to get down lower. What's in that now? Because we've got to a point where we've been fairly sustained in our improvement work by applying a universal approach. But now, is there something that we need to do more targeted for the group of people that we haven't really looked at? Is it because actually they're getting everything that they do when they come in, but they don't have antenatal contact that we would expect them to have because they can't be released to come from work, for example? There's so many things that we haven't really explored. So this might give us that extra 5% or something that we can look at to make that reduction, rather than just trying to keep hashing the same thing and hoping something different will happen with the same intervention. So yeah, definitely, it's a learning curve for most of all of us. So but embrace it. Don't feel like you need to know all the answers, but just, as I say, ask the questions and challenge yourself to think differently.
Yeah, I love that idea of that continuous improvement, and you get to a reduction through a bundle. And where are you looking at as well for those people, like you say, that fall through the gaps? Or we often within IPC, don't we have a catch-all, and we want to try and be as most effective as possible, but actually if it makes a difference, how do we catch those people who fall in between? I'm really interested in the AMR side of things and how that ties into health inequalities. And with the National Action Plan in the UK, it's really encouraging to see health inequalities being as one of those kind of pillars, along with other things like the built environment and education. So that's a really good example of where you've got kind of a top-down initiative coming, really strategic. But where do you think, if you think about something maybe that I don't think gets enough attention, that I know you're really passionate about, with mouth care, for example, and the links to that and health inequalities, how do you think that we start to make that case for change? And actually, in the absence of that national guidance or that government-led strategic approach, how do you think that we can go about that?
Yeah, I mean, part of I'm hoping that when we have, sort of maybe the next year, because I think the plan was to have a bit more meat on the bone, shall we see, with some of that, because it's easy to say we'll tackle health inequalities, and then that's that. What does that mean? We kind of need some practical kind of guidance. I think a lot of that's probably going to have to come from us as practitioners. So we are going to have to add and contribute to the evidence base in that way. I think certainly if we don't start giving people examples about what we can do, people might not know where to go. And there's nothing worse than that blank piece of paper about where to even begin. So I think a big part of that is sharing stuff that we're doing. I think it's looking a little bit outside the box than sort of what might appear to be traditional IPC. I think that I certainly think when I listen to some of the talks in the last sort of few conferences that I've been to, the fundamentals of care is certainly coming through, and I think actually that aligns itself really nicely with fundamentals of care with health inequalities, because things like getting people up, dressed and moving, getting people having good oral care aligns really nicely with some of the prevention work. Good skin health, prevents some of the kind of skin and soft tissue infections that we know that we see, and contributes to some of the bacteremias that we see. So I think it definitely has to be in the prevention agenda. I think that's how we're going to tackle this. I think it certainly has to be, we kind of need to put ourselves out there, be brave, and share what we're doing. And I think we need to contribute to that evidence base. We absolutely do. Otherwise, I think we'll be in a sort of a few years' time, which is really nice governmental documentation and policy, but very little has changed. I think we need to be the people that do the movers and shakers. We may not. We have to rely on some of our policymakers sometimes, but I certainly see a direction of change. I mean, that's what was interesting reading a lot of the King's Fund documents, was sort of saying, look, this has been said about how to do it for years, but actually it hasn't actually massively made a massive difference, unfortunately. And that might be because there's evolution of the politics and stuff, but certainly concerning that life expectancy generally, there was a certain point of a year that year on year at top, I think it was about till 2020, we saw an increase in life expectancy, and now it's stopped. That's and it's actually dropping. So there's an impact of not tackling some of this on a population level, not just in those individual health inequalities.
Yeah, I agree. And I completely agree with you about, actually getting into the doing and making a noise about it. And that's what's going to start to influence change. We're going to have one more question, Kerry, and then we're going to wrap up.
Yeah, no worries.
Okay, yeah, I mean, I agree. It's great to see AMR in the National Action Plan, but I noticed AMR doesn't feature in the core 20+5 in any
No, it
way,
doesn't.
shape, or
No.
form. I couldn't see it. I looked for
It
it.
wasn't.
It's not there. So maybe next time they revise that, it could find a way in there somehow. I think that
Yes,
would be good to be on that kind of national healthcare inequality
absolutely.
radar.
I completely
Okay,
agree.
so the most studied area, according to this review, was around vaccination. And we've talked a lot about healthcare inequalities in our patients, but what about healthcare inequalities amongst our staff? And I
Yes.
think vaccination uptake is probably one area where we can see that, and probably the area where I can actually see the most tangible road to our role in improvement as well.
Very true.
So how do you think we can take away something really practical from this session today in terms of
Yes.
addressing that health inequality in our staff?
That's a really good question, and probably a tough one as well, because I think if I had
Yeah,
the
it's a
answer to
tough
that,
one.
I may,
Don't
I
ask
may
me. I don't know.
I was going to say, John, do you, Phil, help me out here, because and I have to say, I think most people are speaking to some colleagues across the UK. Everyone's seen quite a fall off in vaccination. I think particularly things like our flu vaccine uptakes. Remember the days where we used to have the sequin and we used to get like 90%? That feels like gone are the days that we did. I think most people are seeing
Yeah.
about the 20 to 60%. I mean, what's been valuable in terms of learning from COVID, isn't it, is that you can't just do a program to a certain community and expect them just to say, okay, here's my arm, inject me. Then that's not going to happen. I think what we've learned from COVID is that you have to engage with those communities, get those community leaders involved, understand about, okay, well, what's stopping you, what's enabling you to go and do it for some people and not for the others. You know, a lot of the programs have now gone into spaces where we bring it to, so I'm thinking like care homes and social care sort of environments. They never used to have a vaccine program. You had to go to your GP, and they're now being brought into those settings to try and give access. But messaging is really important with that. And actually, I think sometimes I think, you know, we kind of get, we put ourselves in a position where we think, oh, we know what people want to have and why they want to have it. So we'll create and design a program because we think that's what they need to know. And this is the best way to approach it. And we're not very good at doing that co-design. So let's speak to those groups of people and understand, okay, well, what would make you want this better? You know, what's the thing that triggers you to say yes and what stops you from saying yes? And so hopefully we could be a bit more intelligent with our approach because it's directly related to the people that's going to impact. So whilst it's not really a very good answer, I think we do it in bits, but I don't think we do it very lot. And then you've also got the context of, you know, I've got this vaccine, this vaccine, this vaccine, this vaccine, and then competing with things like social media and that, you know, if you've only got certain amounts of, if you're accessing information, is that the forums that you're accessing, and is that the right information you're getting? So there's something, how we manage some of that messaging and how we might want to kind of hijack some of those processes so that we give people the right information in a way that they can understand. I said the reading age one is always a thing that I always challenge myself when I read some of the things that we send out. I mean, gosh, in IPC we love to use something that's longer than unnecessarily if we can avoid it.
Full of
Not,
acronyms.
yeah, full of acronyms, full of lovely, you know, bits of Latin, Greek, everything thrown in there at the same time, and then we expect people to understand it, and that's assuming they haven't, you know, when we look at the national reading age of 7 years old, that, you know, we're already kind of missing the point, aren't we? I think I saw in the chat someone saying we try things sometimes, we target it and we miss the point completely. So we need to make sure everything that we're doing, from the information we're giving to how we go and approach those groups, the people, the leaders in those environments, and how we get them to kind of support that message, but also understanding exactly what it's like for them in their lived experience rather than assuming and making judgments.
Thanks,
Yeah,
Kerry.
great comments, Kerry. Just to pick up a couple of quick points on the chat in response to that, from Cherry, just shouting call out to the public health teams actually who are out there in the community doing this kind of thing
Absolutely.
day in, day out. So there's a lot of expertise around public health
Isn't it
messaging
just?
and quite a lot of science about what works and what doesn't work. So we need to
Absolutely.
make sure we access that. And also social media, and how do we address the misinformation
Yeah.
that's out there on social media, and that needs to be some kind of cornerstone of a campaign to right that particular healthcare inequality amongst our staff.
Absolutely agree. Yeah, if as I said at the beginning, my challenge to you all is find that expert, because there is an expert in public health. You know, health protection teams are fantastic at this. This is, you know, to say they were really the light that shone on them during the pandemic is certainly the way in which, you know, I've seen so many fantastic articles and conference talks that have come out as a result of that, of things that worked really well. We need to be duplicating and kind of copying. Pinch with pride is what we say a lot, don't we? I think we definitely need to be doing a lot of that, but also There's fantastic health inequalities groups and volunteer groups that are fantastic. As I say, brilliantly wanting to do stuff, and they love it. That's that's what makes them up in the morning, and they just need a bit of a steer. I was listening to somebody who recently so it was about hypertension, health inequalities, but they had a group of people that they, having meetings every week or so, and they just said, here you go, we'll give you an obs machine, we'll teach you how to do it. You can do blood pressures in this space, because they didn't even need a healthcare practitioner in it, but they just trained them effectively. And because it was from a voice of a person that they trusted and they'd seen every week for however long, they had the same accent, the same they had the children in the same school with them, they absolutely was like, yeah, here you go, crack on, that's fine. And they'd seen a massive increase in their screening for hypertension and managed to get access to the right management. So yeah, we need to be tackling those groups and asking for their help.
Yeah, and making it relatable, I think, is the key.
Yeah,
definitely. Kerry, thank you so much.
My pleasure.
It's really interesting insight, and I learned a lot, and I've taken away a lot from it personally, and I know all the audience will have as well. So thanks very much, Kerry, from John and I.
Thank you.
Just really briefly in the last couple of minutes, this is our schedule for the next couple of journal clubs moving forward. So I'm delighted to have Dr. Izzy Sentaligi on the 26th of February, talking about something I'm really passionate about biofilms and sink drains. Then we've got Dr. Alex Edwards talking about ventilation. And then we've got Candida auris, an emerging threat, which John will talk us through. And just a reminder that you can see all of our schedule on our website, which is there, and all the recordings are available on our YouTube channel. Again, Kerry, thanks a lot, and have a good afternoon, everyone.
Thank you so much.
Cheers, Kerry.
Bye-bye.
Bye. Take care.